seizures are what type, you think? You think they're more focal or they're more generalized? Generalized. That's right. Why did you say generalized? You're right. That's absolutely right, Melissa, because you're talking about a febrile state. So it's not just affecting one part. Where you would see focal seizures sometimes is if somebody has a tumor, let's say, that's affecting one area at that point. Maybe not really, then you might see like an eye twitching that'll occur. Mm-hmm.
An aneurysm.
Correct, an aneurysm, that's right. Some sort of abnormality in one section of the brain. When there is a traumatic brain injury, like an accident or something of anoxia to the brain, you are putting the brain at risk for seizures, and those would be the generalized type. The tonic-clonic things that you see, in the movies, or what you're used to thinking of when you think of seizures. Okay, the whole body is involved. There is a period of there is an aura that occurs beforehand. Okay, where somebody knows something's going to happen, and then you have that period of the seizure, and then you have that post-ictal stage. Right? Does that sound familiar? Where they kind of are, they're kind of disoriented, doesn't know what happened, scared, nervous. You want to watch they don't injure themselves. They try to get up quickly or do something. Might be sluggish or lethargic. People respond differently, but those are the things. When children have febrile seizures, they are usually because it runs in their family, but sometimes it doesn't. Okay, so there is sometimes that it doesn't. Sometimes associated with certain kinds of diseases, like meningitis, kind of runs with a higher. When they get the higher plus with the meningitis, they're at a higher risk for seizures. So certain types of diseases have put them at a higher risk for that. And the other thing that puts people at a higher risk, too, of having seizures is if they've ever had one before. So once a child has a febrile seizure, as it says there, 33% will probably have another one when they get increased temperature again. And it does not necessarily have to be so high. Some children are very resilient. They can have fevers of 104, 105, and they will never seize. Brain is resilient, doesn't respond that way, can maintain the high temperatures, and it's not a problem. And again, some of it's genetic and some of it's the way the body responds. But some children will raise very rapidly and they'll get to 101 or 102, which is not truly so high in young children, because it can get very high. They'll get to 101, 102, and here they are having a seizure already. Okay? So it's just the way their body handles that temperature, that increased temperature. But once they have been known to have it, they're always going to be at risk to have another. So then you do not want that fever or that temperature to get so high so quickly. These are the children you're doing hourly temps on them. You're treating them immediately. You're going to give them medication. These are the children that you're going to be making sure, you cool them down. You're not going to want to wait to cool them down either. And only 3% develop on to be epilepsy. What do we mean by that? Epilepsy is a seizure disorder where for the rest of their lives they need to be on medications like Dilantin, and controlled in seizures for the rest of their lives because they're at risk for it. Only 3%. So this is truly not a long-term disorder. It's something that once their brain matures, the thought behind it is that some people's have immature, all children in the first years of life have immaturity in the brain. And that immaturity in the brain cannot handle the high temperatures for some children. Some handle it better than others. The ones that cannot are more likely to have seizures when the temperature does raise and go very high. Does that make sense? So that's really the concept out there. So for those children, we need to act quickly to take care of the causative agent and to keep their temperature down. And that's really the goal there. So again, seizure does not need to be with such a high temp. It could just be high 101, 102 even. It's how fast it goes up. It's fast, but then how fast, too, is one of the key factors. How high and how fast. Seizure activity occurs during the temperature rise rather than prolonged elevation. So if you have a child who's been sitting there with a 102 temp for a while, they're not as likely to have the febrile seizure as another child whose temperature was 99 last hour and all the way now is up to 102, 102.5, 107. We got to jump on that. Do you see what I'm saying? Some children, their temperature rises slower than others. So you can have a child that all day you were taking care of them on the unit, and maybe you're going to treat them with Tylenol if it gets to 101, and all day it was hanging at 99, 99.9, 100, but it's not really raising quickly, even though you're taking it every hour, every 2 hours. And then you have that second child who might have had a tempo 99 when you came on, but now it's 102 or 103 in the next hour. That's the child that's at a higher risk for having, do you see what I'm saying, with the febrile seizure? Because it's that makes it And most of the time, I think I had mentioned this too, certain diagnoses also tend, like a meningitis of otitis media, pharyngitis, and adenitis, have a higher incidence of febrile seizures to those type of infections. Okay, so what do we want to do for these children? Obviously get a history if they've ever had a seizure before. The hardest thing for the nurse in this case, and what I've seen historically, is that when they come into the ER, the family will say they had a seizure. They had a seizure when my child, I think we had a case either this semester or last semester too like this. And you're like, okay, so describe what happened to me. Well, they were shaking very violently. And sometimes you don't quite know. Some parents are very clear. And it was a seizure, it truly was a seizure. And then some, it's like, okay, so were they shaking, shivering? Was it, did they lose consciousness? No, they were looking at me, but they were scared. And so then you're like, was it a true seizure? Do you know what I'm saying? Like, and there's no way to really know because we were not there and we did not witness it. And they're coming and they're telling us, but you know, maybe they don't even know, or maybe they think they know. So again, what becomes hard with the diagnosis is when, okay, so we know they have a high temp, we have to treat that. And then what they do a lot of times too is they'll do an EEG to make sure that the brainwave activity is not abnormal. And that to watch, and sometimes they'll even do a video EEG where they videotape and they do the EEG for a few hours to see, you know, to make sure that the child is not having even smaller seizures, or to watch as a brainwave pattern to how the child physically manifests what they're showing. But for the most part, if it is something like if they are having a true febrile seizure, then, you know, whether or not it's suspected whether they truly have it, you want to react as if they did have one. Do you know what I'm saying? So you want to educate the parents as if they did have one. You want to respond to it, and you're still going to respond the same way. These are not children that go on anti-seizure medications, because these are usually children that you're going to watch, monitor, make sure you treat the infection, tell the parents to be very proactive and to give medications and lukewarm baths, you know, again, room temperature tepid baths if they think that they are having a rise in their temperature. And again, if there's a familial history, if you have a father or mother come in and says, I used to have febrile seizures as a child, that would also make you more inclined to obviously be proactive with this. So identify why it occurred, like what is causing, Stephanie?
What is torch titers?
Torches, anybody, did they go over that with maternal OB? If it's a young infant, torch is all those things, toxoplasmosis, the O is actually other, R is rubella, C is cytomegalo, and H is herpes simplex. Those are some of the more common diseases or viruses that children can get in the newborn period or the first few months of life that will pass on from the mother. And they can run torch titers to check for those. But those are like communicable diseases from the mom that they can get, they're very young. Immaturity, like the younger the child is with these high temps, the higher likelihood obviously of a seizure too. So what are we going to do? We're going to correct the causative agent. So if they have otitis media, we're going to give them antibiotics, depending on the type, right? Which usually will be acute otitis media that would cause this. So we're going to give them antibiotics. We're going to do something to treat them. Correct the causative agent. Seizure precautions. So what are seizure precautions? What does that mean when you say I'm putting a child or anybody on seizure precautions? Pad around. But you just told me a couple of weeks ago that we don't want padding in an infant's crib.
So contradictory.
Yes. Why do you not keep with what, yes. But in this case you need it, that's right. So we're not putting things, we're going to make sure they're secured appropriately. You're the nurse, you are responsible for putting them on and making sure they're secured and monitoring that they stay secured. So if the infant pulls them or something happens, make sure you secure them, you know, educate the parents. But yes, you need the pad. And by padding, I don't mean putting a pillow there. You know, like real padding that the hospital provides that are going to be there. In this case, you need it. That's right. What else is seizure precautions? Yes. Kind of bed down.
The 4 rings up.
Yes, you want to keep them up and padded, yep. The other thing that's big with this too is neuro checks every 2 hours. So they do neuro checks. As they get closer to being discharged, they do them like every 4 hours, but usually in the beginning it's neuro checks every 2 hours. Where you're checking almost like the Glasgow Como. You're checking how their strength is, motor, you're checking their eyes, their responses, their pupillary response, and you're checking to make sure they're orienting and speak to you if they're old enough, obviously, what their vocalizations are. So it's very similar to a Glasgow Como every 2 hours that you're checking on them. And then the other thing is bed in lowest position, I know somebody said. But the other thing is too, if you should walk in the room and now they're having a seizure, what do I want to do? So like a rescue position. take things out of the way?
Support the head.
Okay, so I'm gonna hold that head down, right? She said support the head, I'm gonna make sure I hold that head down, right? Hold them down.
No.
How do I support the head then?
Something under it.
Cradle between your legs, I think, something like that.
You just make sure you're
That's right, Ina. If you have it depends on where the patient is. That's a good point. Okay, look at the situation. So, excuse me. Sometimes all you want to do is observe and not touch them at all. Like if you literally walk into a room and they're seizing and they're in their bed or their crib or something, we're not going to touch them. We're not going to do anything. Okay? We're going to time it, try to find out how long it's lasted, and continue to time it. Does that make sense? Because, again, if you start to restrain somebody, you start to move them too much, you start to grab their head, I mean, again, depending on their age, obviously small infant, but, then you're going to actually possibly injure yourself, possibly injure them more. You never want to stick anything in their mouth, and you want to clear the area. Somebody said that. You want to make sure the area is clear if you do walk in. Like, let's say you're a school nurse, and you walk into a room and there's a child that's seizing. You want to clear the area. You want to clear the people out of the area, and you want to be timing it. You want to have somebody notify and get emergency services. So these are the kind of things you want to think about. But I would avoid anything that says holding them down, trying to stabilize them, because it really is very difficult, especially as the person gets bigger and older, to really be able to effectively do that when somebody is truly seizing that way.
You would put them in the rescue position after, right? Like
Correct. Correct. And that's my point. You can't really do much with them when they're like that. Now, it's very easy for young infants to place them in a rescue position. So, but even then, you don't want to be, because a lot of times their bodies are they stiffen, and they're extremely stiff. And it's not easy. Even a young child that's very stiff, it's not easy to be, and the more you try to manipulate them, you can break a bone. Again, you can injure them, bruise them, and that becomes a liability. So the best thing to do is make sure they're safe. Assist them if they're hanging somewhere. They're somewhere where they could be injured, or obviously they should be on the if they're I'm talking about not in the hospital. Then you want to help make sure they're on the ground. Make sure again, but make sure there's nothing around them that's going to injure them. And then immediately following, they should be in the rescue position. Go ahead, Talib.
You want to provide low-by oxygen?
If you think that you can safely, yes, that's not a bad option to oxygen near them. What he means by blow-by is